What an interesting thought. I mean, I've not heard that perspective before, and my brain is over here just like.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare.
Well, let me ask you this. There's catabolic things going on in that joint, obviously, if it's deteriorating and degenerating. And so, I mean, I agree very much with everything you're saying, but at some point, that catabolism is going to continue, and something needs to either shift it to more of an anabolic pathway, or it's just going to continue to be catabolic. I mean, you can improve, I think, range of motion and strength and function, and that's going to go a long way. But I'm obviously a lot older than you, all of you, and there is degeneration in my body. You can see it everywhere. Does it always cause pain? No, but we are inherently breaking down.
Well, degeneration happens. The more you age, the more you're going to find something on imaging. But the question is degeneration related to pain?
I completely agree with that.
And if you look at people that have degeneration, many of them don't have pain.
Right.
If you look at those who have a lot of pain, they don't have degeneration. There's no correlation.
Agreed. But he's got pain and apparent degeneration. And at what point, like...
And it's an assumption to assume that bone on bone is causing pain.
I agree, because we see a ton of knee bone on bone, and that's a very forgiving joint that actually responds well to injecting bone marrow concentrate into it. Because people, that's their first thing. Oh, my surgeon said I got bone on bone. I'm not appropriate for any of this. I need a knee replacement. But in our randomized control trial, everyone was bone on bone.
Yeah.
And they got better with...
So why did they get better if they still have bone on bone?
Because the only thing I could say is we shifted the joint from catabolic to anabolic.
There's something there, because when I had a similar procedure, when they said it'll take about 7 to 10 days for it to start working, and it was like day 3, my joints did not have pain. And I don't know if it was something in the concentrate that they injected into my joint that changed, that just removed the inflammation that was there, or if it did something.
That's what those cells do.
Every one of my joints that I had the injection into, literally, it was like I woke up and I was like, oh my gosh, I don't have any pain. And I didn't have pain for years.
Let's hold that thought there, because I don't want to miss the conversation, and we might include that run-in, to use a stop-loss term. But let's start the podcast. That way, we're definitely capturing all this great dialogue. Okay, so real quick, we got a special episode of Self-Funded with Spencer podcast. We have a MSK Roundtable that we're going to do today. All of you guys have been featured previously on the podcast, so we won't go deep into your bio. But Chris, if you'll start us off, and we'll come this direction. Real quick, who are you and what do you do for the audience?
Yeah, so my name is Chris Hamilton. I'm a partner and benefits practice leader for Hotchkiss Insurance. I run our statewide benefits consulting practice. I work with employers to help them reduce the cost of healthcare and insurance in their business. And I'm really passionate about this particular topic because it's one of the top drivers that we see inside of just about every employer-sponsored health plan in MSK, musculoskeletal costs.
But one other thing about your bio, you're also the first 4-time appearer on the podcast as well.
Do I get an award?
2 weeks, you're going to be number 5. You have your 5th episode. So thank you for always being willing to lend your voice. Heidi, why don't you real quick introduce yourself as well?
Sure. I'm Dr. Heidi Ojha, founder and CEO of Aware Health, and I am very interested in forming this company as the leading expert in diagnosing in an upstream direction any orthopedic conditions.
Okay. Very cool. And Mark, real quick, you as well. I just want to make sure people can go back and watch previous episodes. Yours isn't out yet, but obviously they'll get a chance to hear a lot about you. But just so that everybody knows what particular lens you're looking through. So Mark, what do you do?
Yeah, great. I'm a chiropractor, Dr. Mark Testa, chiropractor and acupuncturist clinically, but I've been working with Regenx for the last 15 years on the business side, helping people get access to expanding the continuum of musculoskeletal care using blood platelets, platelet-rich plasma, and bone marrow concentrate.
And so we've shortened the legal, like, what do we used to say, bone marrow concentrate that contains stem cells, right?
We used to say that.
So what do we get to say now?
We're just saying bone marrow concentrate.
Okay, cool. That's a lot easier to remember.
Yeah,
Okay.
yeah.
So why don't we define the problem? So I said MSK. So let's even define what we mean by that categorically if people are unaware. And then Heidi, if you could sort of give us the scale and the scope of this problem, because I think it's a lot more significant than a lot of people realize.
Yeah, so self-insured groups and their advisors are looking for ways to deliver better quality care at low cost. And so if you look at this whole continuum with orthopedic conditions, obviously prevention is going to be the cheapest.
Okay.
You prevent an ACL tear, then it's a bunch of exercises that can get them in shape to possibly prevent that tear. If you can't prevent it and you treat it downstream, then physical therapy is going to be a cost. And then if you treat it further downstream and that doesn't work, then maybe there's a way for bone marrow concentrate.
Bone marrow concentrate.
Bone marrow concentrate.
AKA Regenix. Yeah.
Right.
Yeah.
Which might be a little bit more expensive, but then much cheaper than a surgery.
Yeah.
And so the revision surgery is even more expensive. So the more you go down that continuum, the more cost, and I think the poorer outcomes personally.
And I think it's an argument against the kind of the current status quo, right? As we go way too fast down that continuum, or we skip steps on that continuum and go often go straight to surgery. Right.
4 steps, right?
Well, but can you confirm my numbers? Because I've heard, roughly speaking, healthcare makes up about $4.5 trillion of our GDP, which is like 17.3%. I looked this up yesterday. But I also read that MSK is 27% of that spend. So that makes it $1 trillion category of healthcare. And I think most people don't realize that. And Chris, I'd love your perspective because you're in the insurance business. Like, it just doesn't pop on our radar because it's like these aren't the severe, big claims we're concerned about. Stop loss carriers aren't talking about MSK all the time. And so why do we think this category is sort of ignored, unfortunately? I'd love to hear you first. And please, you guys can interject anytime and ask questions of each other, please.
I think that's a really important point that you make, because if you think about the big things that people pay attention to, it's cancer, it's specialty medications, it's gene therapies. Why? Because they're eye-popping numbers and they stand out. But when I think about musculoskeletal things, whether you're talking about an ACL tear or a rotator cuff or a hip replacement or knee replacement, those are a little bit more expensive, but they're not astronomical numbers. And so the reason why they add up to big dollars is because they're one at a time. So when you look inside of a 100-employee company, you might have 1 or 2 specialty medications, and we know who those people are. But inside that same group, you'll have a number of orthopedic issues, broken arms, torn ACLs, a hip replacement, those sorts of things. And they just add up in aggregate to very large dollars.
Well, not to use we were talking double entendres before, but it's death by 1,000 cuts, right?
That's
really
exactly
what's happening here. And I didn't mean to step on the kind of the continuation of that question earlier, Heidi, which is that skipping ahead, right? The main issue appears to be, and Mark, I know you weigh on this, we just go straight to surgery sometimes as the first protocol, when it's like, wait, what's going on? Why are we so quick to cut? So why don't you guys weigh in on that, maybe that question right there?
Yeah, I think really what research supports is a stepped care approach. And what we're finding is that when we try to prevent a problem, people are not as motivated. Like, if they don't have pain and we're trying to prevent back pain, it's a tough sell. People are busy. They're not that forward thinking, right? But when they have 8 out of 10 back pain, that's the perfect time to intervene because they really want to do something about it. And they're motivated. And then we revisit the prevention part along with treating it upstream because they're motivated to do something more about their health to prevent that future episode.
Yeah.
So, I think that, did you want to add
I
something in there, Mark?
think part of the reason we skip a lot of steps is because people have 8 out of 10 pain and they think that it's just debilitating. I can't live with it. I don't want to wait. And frankly, primary care doctors who might see that person first are not really good at diagnosing musculoskeletal stuff. So they immediately punt the ball. And I've seen this because I practiced in primary care. The next step was to the neurosurgeon. And I'm like, this guy's got 8 out of 10 back pain, but he doesn't have any of the major signs or symptoms of, squashing the spinal cord, right? We'll skip the big medical term on that.
Squashing the spinal cord, I can follow that.
That
yeah.
would require emergency surgery, cauda equina syndrome, right? Which I've never seen in 35 years. Even the orthopedic surgeons I practiced with hardly ever saw it. But nonetheless, a lot of pain must mean severe. I got to have surgery.
Yeah.
And that just skips over everything. I've seen that.
Well, and I think it's a natural as a patient, right? And I understand that choice. It's like, I'm in severe pain now. I need immediate relief. You are suggesting that if I get this surgery, I can have said relief.
Yeah.
Makes sense to me. Let's do it. I'm in pain. I'm desperate, right? And so if you meet, your mind goes, well, that is the most obvious intervention because that's what my authoritative figure, this doctor who I respect and is an expert, suggested I should do it. Then I'm going to believe them, and I might find myself down this path without really questioning, is it appropriate? I just want pain relief, right? So how do you deal with the psychology of that, right? And if I'm a patient and that is what is suggested I should do, I believe them most of the time, right?
I think you're absolutely right.
Yeah.
It's patient demand or expectation paired with a system that gets reimbursed really well to do images and surgeries.
Yeah.
And so there's no motivation in our current system to introduce those earlier steps for the stepped care approach.
Well, and we've all seen this too. It's like if I'm a surgeon and I cut, that's how I make money. And so what am I going to recommend besides you need to get cut into, right?
Yeah.
Chris, I feel like you're thoughtfully listening here. I want to hear your thoughts here.
Well, just hearing the dialogue back and forth, it makes me think about access to care and how things get paid for.
Yeah.
And this is kind of like we're victims of our own design in a way. So Mark mentioned where the primary care is referring to the neurosurgeon. What I see happening all the time now, and this is because of the emergence of PPO networks, patients are self-selecting to just bypass primary care altogether, and they're going to the specialist, and it's almost like the fox guarding the hen house.
Right.
If I show up, and it's happened to me personally, where I show up at an orthopedic surgeon's office to get my knee checked out, he immediately recommends we should do surgery. Why? Because that's how it gets paid.
Okay.
And so insurance is designed now where it's almost a free-for-all. And so I go back to thinking, how do we create checks and balances? Because patients aren't always empowered. They don't always have the information they need to make the best decision. They trust the doctor wearing the white lab coat. This is what the doctor says I need to do. So how do we create this ecosystem, if you will, where patients get access to what they need, but we have a way to do it in a very judicious way or a very...
Well, I think you asked the question, but I'd even like you to maybe perhaps answer part of your question because I think you're probably well suited to do so. So what would that look like then as a result?
I think providing more access to primary care.
Okay.
I think people skip the primary care physicians now because the very first impediment is a lot of primary care physicians are getting out of the practice.
Okay.
So when I call a primary care doctor to get in to see for an acute issue of a knee pain, it may take me 6 to 8 weeks. Well, people don't want to wait that long to be seen.
Yeah.
So I can call a specialist and get in immediately. And in my mind, that's really who I need to see anyways, because he's the specialist.
Mm-hmm.
Can I challenge you or ask you something about that? Because I'm really curious about this. So my question to you is, should they see a DPC first or nurse navigation if that group has nurse navigation?
Oh.
And the reason, so like if we follow out those two pathways, if you go to a DPC, they may know the clinical practice guidelines for imaging, they may not. They might order an image for stiffness in the knee when it's not indicated and find bone on bone, which could then plant the seeds for a joint replacement later on. If you go through nurse navigation, then they would know, okay, Aware Health is an option. Let's do a virtual bout of care. And then if imaging's needed, we can route to an imaging center that's contracted or something like that. So those are two examples, and there's probably lots of different types of examples, but what do you think?
I love that you asked me the question and then you started answering it because
Guilty, totally guilty.
This is the power of collaboration.
Yes. Yeah.
Because I would have answered the question I would send directly to DPC, but the reason is because it's the vantage point that I look at it, but you have information and knowledge that I don't possess. And so by you and I talking, it opens my eyes to other perspectives
Yep.
that I wouldn't have thought.
I'll try to remove my opinion out of that.
No, because
but I really want to
honestly,
know.
I
It was
want
really
like, there's a reason why your three voices are on this podcast right now collectively, right? This is almost like a collaborative brainstorm with the audience getting an opportunity to hear it, right? And so I want it to be organic and
because we're facing this with some groups right now.
So I'm going to answer the question with the preface of that you just gave me a different viewpoint that I've not had before. So the way I would have answered that question 90 seconds ago is I want patients going to the DPC first because I want a doctor to put their hands and eyes and evaluate that patient to understand what is going on with this patient. And then once we've made a diagnosis or determination of a care path, then get them into a navigation to go to the right place. Because I'm not a clinician. I simply pay for the care. I look at this from a standpoint of somebody's got something that's broken or hurt. They're going to get it taken care of. How do I pay for it? So my focus has purely been on how do we pay the best price for this episode of care. And I need somebody to get engaged early on and then to help diagnose it, and then we navigate them. But what I hear what you're saying is maybe we're pushing them into a path where they don't need to go down that path. There's an alternative path.
Yeah.
So that I'm interested in that.
I want to say, how much does inertia actually play a role in our health plans, right? It's like nobody goes, wait, stop. This is inappropriate. We need to go here. You just kind of continue down this path until it has some sort of conclusion that's natural based on the pathway. Yeah.
Well, the reason why I like the direct primary care model is because their incentives are very different than the traditional fee-for-service doctors that are owned by a hospital. So if I'm a primary care physician and I go in to see them for knee pain, they're forced to refer me to somebody that's part of the hospital network. And then that doctor is going to do the surgery because that's how he gets paid. And he's going to get the images from the hospital imaging center. They're going to do the surgery in the hospital. So very much so in the traditional model, there is a lot of inertia because that's how money is paid. Sick people or healthy people don't pay the bills in a hospital. It's injured and sick people. That's the only way they make money. DPC makes money by keeping people healthy and happy when they can. And so that's kind of why I'm glad you pointed that out. Direct primary care is very different, and it's very important to kind of understand that perspective. So inertia is very real in every industry, but specifically in healthcare.
Well, I actually want to take a second to pivot just because, Mark, I don't think we've done a good job of defining what you do real quick, because you're going to layer into this conversation, but until people quite understand, if they've never listened to your episode, they might go, what is that Regenix thing? I didn't really get this. So tell me what it is you do, how you intervene, when it's indicated, et cetera, and then let's kind of go from there.
Yeah, thanks. So we use the patient's own blood platelets and bone marrow concentrate. We're a step before surgery, right? We are sort of the last stop before surgery, but now there's this stop that people didn't have before. So we fit in, when we want people to get a diagnosis, do good physical therapy, right? We know there's a difference between good physical therapy and just physical therapy. Do the conservative care first to address their problems. And if they still have pain, then now they have an option, right? We can do these regenerative treatments to their joints, to their ligaments, to their tendons. So it's still a conservative treatment before surgery. And that's where we fit in that continuum. And
surgery has to be indicated, right, for it to be appropriate, or no?
Yes, in the self-funded space, our value prop to the employer is surgery avoidance. Not physical therapy or other conservative care avoidance. It's your next step in your plan, if you're not getting better, is surgery.
Okay.
And that's where we fit in.
And that's so that you're trying to prevent ultimately that final step, which is what we've been talking about. Okay, that makes sense. So then let's try to talk about that continuum care, Heidi, right? We're building through that progression. And I think one of the notes I was looking at real quick is like a lack of standards for diagnosis is one of the things that you guys said. So is it just all over the map and it's subject to the moment and that doctor in that situation? Or when you say there's a lack of standards, what does that mean in your mind?
Clinicians are not practicing according to guidelines that are published.
And what are they doing? Just ignoring them altogether and just running their business as they see fit? Okay.
Exactly for the reasons you said. It's the patient demand, and it's the system that benefits from that. And there's no stop mechanism in place right now.
And treating pain, right?
Yeah,
they see pain. They want to diagnose pain. They get an image. We were talking off camera. In Colorado, there's work comp guidelines that says, really, unless you have serious neurological problems, no imaging for 6 to 8 weeks. And people fight it. because they're like, I'm in pain, I need imaging, you're not treating me right. That's a lot of pressure on a doctor.
Okay.
And then, but we don't let that pressure dictate the care. When we as clinicians know better, you don't need that. It's going to lead to, because we're going to find something, even on asymptomatic people, and that means it's going to lead to something. And that other something may be completely inappropriate.
Yeah, so there's diagnosis from like, is imaging indicated? And so we have clear practice guidelines showing that out of all orthopedic cases that are elective, meaning like they're scheduled, only 5% of those should be imaged. But right now, only 5%. So right now, 60 to 80%, depending on which provider you go to, you get an image.
Okay.
So we're bringing that way down. And so that's my question about DPC. It's like, are they trained to know all those practice guidelines and bring that imaging rate down? Because when you see something, like when you see bone on bone, you just picture your joint wearing out every time you take a step. That visual is so powerful. And I know that at least with back pain studies, all other variables accounted for, it triples your risk of going surgical route when you see your MRI.
Well, it's a confirmation bias. You have pain, then you see something on the screen that suggests, oh, that maybe that's the source of said pain. Okay, I know it's there now, and I know that's the cause, right?
So imaging is one, but then the second part of it for diagnosis is we're underappreciating our thoughts and beliefs and how they feed into our pain experience.
Okay.
So if you look at claims for orthopedics and you look at the downstream claims that are the most costly, what predicts that downstream cost? It's anxiety and depression that show up as comorbidities in the claims.
Okay. How do you find that?
So is a typical provider asking questions about people's thoughts, beliefs, and other mental health sides of the pain experience? I don't think so. I don't see that being done. So I think that's really important to talk to the patient and get that history so that we are picking up on some of these risk factors that can predict that downstream claim.
Interesting. Well, I can tell you, and then this may be back in my days as an athlete, I would get really depressed if I was injured, and it would, because it prevented me from doing what I wanted to do, which was play the game, right, or practice, and that would have a snowball's effect, and I'd feel like I'd focus more on the pain because I was depressed, as that pain was preventing me from playing. So I could see where that would feed into it. But how do you attribute the anxiety and the depression to that experience, and how do you identify that maybe that's amplifying that experience for that person in that situation? I'd love to kind of dig a little bit further into that.
Yeah. So first of all is recognizing it, and it could be the chicken or the egg kind of thing. Is it from the pain, or did they have baseline depression that puts them at risk for a longer recovery process? Okay. So once you parse that out through talking to them, then you can treat the depression, which is a moderator of the pain, and then you can treat the injury simultaneously. So what that would look like is doing an aerobic exercise program that's shown to have a bigger effect size than antidepressant medication for the depression. Okay. And then you're treating the contributing factors to the actual injury at the same time, but you're dealing with the physical and mental health sides of the problem. And that complexity is not appreciated in the current system now. And so that's kind of my hesitation when you go directly through DPC.
Chris think this whole time, and I'm like, man,
my brain is like,
I literally, like, you went deep in.
What an interesting thought, or just, I've not heard that perspective before, and my brain is over here just like, because we have data, and what I would really want, this is the data side of me. I want to go back and look through data to determine, of all the orthopedic surgeries that we've paid for, which of those folks had depression or anxiety diagnosed before they started seeking treatment for orthopedic care. Because then I would want to, that would help us determine the correlation, and then maybe perhaps it's hard to determine causation. But if you can see that there's this data set that we have, that there was long onset of anxiety, depression, and then downstream there was care path for orthopedic treatments for pain, I think that would support that. So that's the side of me that wants to go back and look at all this data to figure out, what does the data tell me?
It makes sense though, right? Like if you have somebody who's baseline an anxious person, okay, I I actually got treatment for my daughter because I thought she had anxiety. And then the counselor told me that I had anxiety, not my kid. And I was like, oh. So it's common, right?
Yeah.
And take a baseline person with anxiety, and then you show them an MRI of their back. And the interventional radiologist or the radiologist interprets it without even talking to the patient or putting the clinical context. They have to report every single thing on that image. So you put that scary image in the hands of a patient, and is that going to increase their anxiety or not?
Of course it is, yeah.
And so like that's where over-ordering imaging can be harmful.
Okay.
And put them on a course to surgery because
You said it's a 3x, or 3 times likelihood to get, okay.
for back cases.
Okay. What can we quantify that problem real quick? Because I think back surgery is probably one of the most egregious offenders. I know you probably have some stats there, but like, what percentage is suggested of back surgeries, especially, are unnecessary or avoidable?
At a minimum, half are
At a
unnecessary.
minimum, half.
Yes,
Okay.
and
Would
it
you
might
agree
be
with
even
that as
higher.
well. Do you think it's higher or lower?
Well, you're talking to somebody who is bent on avoiding all unnecessary
Okay,
surgery.
yeah.
So based on our data, 95% of these elective cases coming into us are not showing up in claims later on for surgery.
Okay.
So,
Over what kind of timeline would we say?
well, we've been collecting data for 2 years on about 1,200 cases, I
Okay.
think we're up to right now.
Okay. So that'd be my question, right? That you probably could draw a continuum with like over a 5 or 10 year period where those progressions might be a little less egregious than 95%. But to your point, I've had a surgeon on this podcast who looked at quality scores, and he told me, especially in Texas, like 85% of back surgeries are unnecessary.
Especially in Texas.
Especially in Texas. What is it about Texas?
A lot of
we think we're all
surgeons
great
here. A lot of
Okay, all right.
surgeons. And so when you have a lot of surgeons, you got to take all comers.
Okay.
As because they're your clients, right?
Yeah.
The patients. So
I think it's interesting when you look at the kind of on the payer data, and from our viewpoint, the data that we see suggests that over half of the surgeries that are done are not considered successful because people are still seeking treatment for back pain even after they've had the surgery within 1 to 3
Right.
years after having that surgery. So that would tell me that the surgery was either not done correctly or it was inappropriate to begin with altogether.
And
so
like Heidi said, everything's multifactorial. So, there is no one pain generator, right? There was the whole pain generator theory for a long time, which still people a lot of practice. Like, oh, here's the one problem. It's not one problem. It's multiple problems, including our biopsychosocial. And people in pain have an increase in
Thank
anxiety.
you, Mark, for saying that word,
Biopsychosocial.
biopsychosocial.
All right, I need that defined for me.
say that 3 times fast.
Biopsychosocial. Let's go ahead and get that definition.
The biology, right? The actual anatomy and physiology, the psychology, the anxiety, the depression, the seeds being planted by surgeons and pain docs, and all the social stuff,
Yeah.
the social determinants. How are your family and friends coping with you? Do you have support? Do you have relationships that enhance your life? It all is a holistic thing, which requires. Just staying on this topic, musculoskeletal, an integrative approach, because we all have different points of view to bring health back to a person. It's not just, if you send them to the surgeon, they're going to surgeon. If you send them to an injectionist, they're going to get steroids. You send them, that's what they're going to get. And that just it's not a holistic, it's not a thorough treatment. And I think where we fall down, right, I've practiced integrative care. I could go down the hall and say to the physical therapist, can you check this out? Or the surgeon, hey, what do you think about this? That's when eyeballs meet and people get a good, appropriate diagnosis and treatment plan. I just don't think we can build that without people like you. I say this all the time. We have the ideas as clinicians, but we don't build the plans.
Yeah.
We need someone insightful like you who's like, oh yeah, this makes sense. Let's do this step therapy, but I got to be the one to build it.
Yep.
Because if the employee doesn't have access to it, they're skipping steps.
Right.
But we can't do it by ourselves.
Well, Kristen,
And-
what does that look like from a benefits perspective? Because ultimately, this is our audience is benefits consultants like you, and we're trying to solve it through the employer chassis. So, what would we do from a benefits perspective to have that care coordination?
So that's a really tricky question because if you think about any of the benefits advisors that are watching this episode, they're thinking to themselves, most clients want as much open access as they can. They believe they need to have the biggest networks with the least restrictions. And many advisors today and many insurance companies, they're removing any of the gatekeepers that prevent people from jumping straight from I have knee pain to getting the surgery. They're making it easier, not harder. And so I think there's a big education that has to be had with employers to help them understand why some of these gates are important to have to ensure several things. One, it's appropriate treatment, it's appropriate access to care, and giving people what they need, but also keeping it sustainable from a cost perspective, reducing costs, but keeping costs sustainable. I think if people understand that, that's the big hurdle that we face.
Well, so let's say we put some guardrails in place, right? Employers listened to you and said, all right, we're going to narrow that access rather than open it up. But who within the framework of those benefits is going to help a member, what Mark just described, which is it physical therapy? Is it aerobics and maybe some talk therapy? Is it surgery or, who's going to help with that conversation? Because the average member has no idea how to make that choice effectively.
Yeah, so I don't see this starting at scale. I think it starts plan by plan. It starts employer by employer. So self-funded employers are going to be the first takers of this. And they're going to design a plan that incorporates each of these components, whether it's early intervention with MSK, it's going to be access to Regenex. But then to your question, how does the member get access? How do they, one, know about it? And then how do they access it? What does it look like day 185 into the plan year, right? And I think that's where we have this conversation. Is that a DPC, a direct primary care doctor? Is it somebody on a nurse navigation team? I think probably just from our conversation that we've already had and just from our experience, I think both can work. I typically lean more towards the direct primary care because I know they're not going to send somebody into a cutter immediately. They're going to try to treat what they can in-house. But I also think if somebody does need to go down a care path, that nurse navigation team is able to come alongside the patient. So if a doctor has determined, you've got something going on, let's start this progression of treatment. Your plan now has an advocate for you that is going to help you through your care and help educate you on what options you have available. Okay, you've got knee pain. Well, we want to make sure that you're getting access to the best physical therapy program that you can. And if that progresses, then we've got Mark here that can help educate you on your options of regenerative medicine before we undergo the knife.
Where would Aware intervene, right? Like talk to me, because I know your episode's not out yet. So let's talk about how do you get involved to start that process?
This is super interesting to me because one of the areas where I'm top cited publisher in the world currently in this very specific topic, it's direct access. And so what that means is you can see a physical therapist before a physician. And with all the research on that, the cost is about $2,000 less per claim if you see a physical therapist before a physician. So I guess I'm still coming back to the same question, like how do we set up the plan to incentivize what we want from it, which is better care, reduced cost? If they come through the nurse navigation to us, and we say, number one, you don't need imaging. Number two, there's all these risk factors we need to treat to prevent this downstream cost, like we were talking about, like anxiety, depression, and then coordinate with the DPC to provide continuity of care. Like we pick up, they have hypertension, and so getting that managed from a DPC perspective. I think it's more about collaboration and possibly having that nurse navigator have the workflows in place so that they know who to send where.
Yeah, it's almost you have to establish up front, like best practices when, right? Or like an order of operations. Where are you getting your claims data from? Is it coming from the third-party administrator? Are you getting access to the claims files? Or because obviously there's got to be a trigger for you to intervene. So what does that look like? What's that process?
Yeah, so our goal is to get ahead of the expensive claims. So we get it through the TPA, and if they don't have a TPA, we get them directly from the carrier.
Okay. And what about you, Mark? How are you getting access to data? When do you bring broad into the fold in this continuum?
So we are very proactive on the front end and reactive. So we do get file feeds, right? So once some members have access to Regenex, we can get file feeds and start to see what was going on, and we'll reach out to them. But we're also very proactive in sending out benefit cards and doing educational webinars Because if people don't know they have the benefit, they don't know they have the benefit.
Right,
and
right.
then once they do know, they have questions. Will it work? Will it work for me? Where do you get the cells? How do they work? What conditions can... So we are very proactive in educating people so that they can make informed decisions.
Okay.
And I think that has worked really well, because when we don't do that, we don't see any cost reductions for employers. When we do that, we see big cost reductions. But it takes being proactive to get in front of people.
Go ahead, Chris.
Yeah, I think what you're seeing here, and I think the benefits advisors watching this would agree with me when I say this. I think both of y'all provide valuable solutions to both employers and their employees. One of the big things that advisors struggle with is all of the things that they add into a benefit program.
Yep.
It's confusing to members. They have all these different people reaching out to them, which is where I think what you mentioned, either DPC or really nurse navigation, somebody has to act as that central hub, if you will. Traditionally, for self-funded plans, it's either been the carrier or the TPA, but we find those are not the best folks to be managing these sorts of programs. And so you really need to think about, how do we centralize, because one, it's one point of contact, but two, there's that continuity that Mark talks about, where that central person can look at this episode and know from a holistic standpoint, what are the right people, what are the right resources this plan has to support the member.
So I take it even as a clinician, like I just was on a call last week with the direct primary care clinic group, because the employer has them and us and physical therapy. It happens to be a physical therapy group that has Regenexx built in. But I train, and I've done this numerous times, the direct primary care docs. Here's what we're looking for. Here's what you should do first. Here's who you should connect with. If it's aware, make sure you're working with them first. Then here's what we need. You order the imaging. So I have trained DPCs. I have trained on-sites. I've trained near sites. I've trained pods. I've trained nurse navigators. Again, like you're saying, when you put a solution in play, it's got to be easy for people to access.
Yep.
So, we can't expect an advisor like you to build all of this. I think it's important for solutions like us to carry the water as well, to make sure members understand all
elaborate
this.
on Chris's point, and this is something I've seen over the last 3 years of doing this podcast, is there's this desire to unbundle it all, break it all apart, and find each individual piece that's perfect in that particular channel and try to slap it back together and create a perfect plan. And I don't think anybody's done that yet. And so it's that antithesis of what you might get in a fully insured environment, where it's all handed to you. And even though it's inefficient and all those things, it's all right there. Leaning on a consultant to have to put it all together back again and make it better than what they just left, that's actually the $1 trillion problem.
Yeah.
And so, Chris, I would love for you to continue to elaborate on that, because it's like, as somebody that's been on the point solution side, I hear from vendors literally all the time, and everybody's got a new shiny object and all those good things. It's got to work, and then it's got to work together as a seamless plan. And so, let's talk about how we make that happen.
Yeah, and I look at this from a standpoint of not only being a benefits advisor, but I also look at this as being a patient. I've had my fair share of orthopedic surgeries on both a fully insured plan and our plan at Hotchkiss, we're in a captive, we're self-insured. So I've seen both sides of the world.
Which captive?
We're actually members of the Pareto captive. We have been for many years. We actually have been for many years. I'm an advocate. So I think about the orthopedic surgeries I had when I was on a fully insured plan. Nobody from the insurance company, one of the big ones, ever called me to help me figure out where I should go, if it was appropriate, was it the right price, because insurance companies don't necessarily care. It's not, they've got coordination teams that could do this, but they don't.
They don't.
And I think if these insurance companies actually sought out the best, we call them point solutions in the industry, but if they were to find the best people, they are the ones that could take this to scale.
Yeah, because they can make it way more operationally efficient with
That's right.
all the technology.
They're doing it right now.
Yeah.
They're just doing it with poor players, poor vendors.
Okay.
If they would just swap out and add programs, they could easily do it. They figure out how to do all sorts of other things that are way more difficult.
Right. Yeah.
That make money for them, but different conversation. So,
well, that's a philosophical question that we could go way down the path of. Ask the question, well, why do they work with substandard vendors, or why do they work ones that don't help? You could go down a rabbit hole that might suggest some sort of nefarious intentions. But if they're all out there, and we all have sort of seen the cream rise to the top, we kind of know categorically which vendors are the best, and it's pretty clear, right? Like you could objectively prove that that's the case, and maybe it's 3 or 4 of them, but you can identify who that cream of the crop is. That's who should be selected as the solution. And I don't think our industry has done a good job of helping vet and validate and prove that at scale without feeling like there's a bias that's been infused or who's getting paid to make this recommendation. I mean, that's another one of those things that's just systemic in healthcare.
For sure.
Yeah, and sorry, that was more of a diatribe than it was so much a question. But I am like sort of obsessed with this notion of putting together the best version of healthcare.
Well, if you think about the difference in the two models, right? The big carriers, just name any of the big 4, right? They're already at scale. They don't have to do anything other than work with a brokerage, and the product is distributed at mass. Whereas advisors like me and many others that we work with, they're going out and piecing together plans individually for employers that are customized. And so that's harder to scale. So it's from ground up versus top down.
Okay.
And so big carriers, top down, they've already built it. Just it's easy turnkey. Individual advisors, they're working with maybe multiple point solutions in a vertical, if you will, and it's harder to scale that because it's almost like ants on a dirt mound, right? They're just kind of like going all sort of different directions at a time, and so it's just harder to put people into formation and run it.
It makes sense. Well,
I think just stepping
please,
back for one moment,
Yeah.
though, like the answer, I think, to your question of like, how do we get people to use more upstream approaches? To offer them.
Okay. Yeah, fair.
If they're not on the table, they're not even an option for that member. And I think no copay, no deductible helps. But I also really believe more in the carrot versus the stick kind of way of looking at it, where if we are upstream and people are in pain and we're really solving their problem, it's not like we need to use any sticks, like penalties for not using us before you go through this hoop, or speed bumps like, they, have to get pre-authorization before they get an image. Because it's annoying and people just want easy access to care. And so the more we're upstream and in kind of like giving people what they want, the less we have to like de-incentivize them later on for getting the care that they think
Chris,
they need.
we had this conversation just literally 2 days ago. The incentivization structure has to be appropriate, right? So like we were looking at some of these plans that have like offer $0 deductibles to everybody for every procedure. Anything they want to do is $0. There's not the appropriate structure in place because it's not so much about penalizing them if they don't do what you want to do. It's that structure needs to have an incentive that drives a behavior. But the alternative is, well, your plan functions as normal with your normal deductible and normal copay if you don't choose it. So you're not so much punished. You just have the plan that you have today if you choose the maybe less appropriate path. But if you choose the more appropriate path, now you have the proper incentive in place. And so I think, to me, that's the best way to set up that arrangement. Mark, I'd love to hear. I know you want to add to that.
No, I agree. Give people the easy button there. And like you're saying, remove the barriers to upstream care. Like when I was in practice, I saw you got 10 chiro visits, but you're doing really well. And now I can't come back to you anymore. And I'd see that person in the grocery store and they had spine surgery.
Wow.
Because it was whatever the copay was, but somebody stopped them from the conservative care that they were receiving. And the insurance company, would say, you're not fixing their problem. And my answer would be like, okay, you gave someone a blood pressure medicine. If they stop taking it, what happens? The problem comes back. So some problems need maintenance, and that includes doing home exercise. You gave them the things, right? You've probably seen this in practice. Oh, I stopped doing them because I felt great. And now my pain's back.
I actually think, though, nobody should be on a long-term exercise plan for any pain.
Okay.
Right.
You should go to the gym because you want to be healthy and you want to work out.
Yeah.
Right.
You should never be on exercises long-term for something. There could be the rare exceptions to that. But I think, really good care is giving people's time back and achieving outcomes as quick as possible so that they can resume life, which is the best exercise.
Yeah.
And so, we are in a position at Aware Health to get them right at that week or two of the point of pain, where really on average they're only needing 3 visits.
Okay.
And then they're done. They go back to life. They don't, if they're thinking about their pain and putting that label on themselves, like, oh, I've got back problem, and you keep on thinking every time you bend, oh, I don't want to flare up my back problem. Like, we want them to not think about that painful region at all. And because you don't think about other body regions that you hurt. Like, if you get a headache, you don't label yourself with like, I have a headache problem for the rest of my life, right?
Yeah.
So we're trying to like get people to think less about their problem, not more. And I unfortunately think the stereotype with physical therapy is like 10 exercises, 3 sets, 10 reps, whatever, like just indefinitely.
Definitely, yeah.
Which is not good care.
Well, to a point, and I have a personal experience with that. Like, I used to probably twice a year get a flare up in my back doing deadlifts, right? And I kind of had labeled myself, oh, well, if I do deadlifts, I'm going to get this flare up. And so I would start to avoid doing that particular exercise, which is logical on the surface, right? But then I started digging into it as like, well, maybe the problem is actually a weakness in my low back, or maybe it's a structural issue. Maybe I should look at my hips or my glutes tight, et cetera. And so I started sort of deconstructing where the problem maybe was sourced from, started doing exercises to strengthen my back, and lo and behold, now I could go back into heavy deadlifts again and not experience the pain, and knock on wood, haven't had to experience that in a couple of years. But it's because I did specific exercise to strengthen, to prevent the pain from coming in the future, rather than labeling myself and now diagnosing myself and not doing these movements forever, right? And it's easy if we start telling ourselves that story to say, well, yeah, I've got back pain now. I've just got a bad back, right? And then
You're basically your own doctor of physical therapy there.
Yeah.
Like, you just diagnosed and treated yourself. That's amazing.
Well, I have an exercise science background, and I don't know if that has, but I'm just one of those people that just goes out and looks and goes, well, okay, well, if this is happening, what are people doing for it? And there's a knees over toes guy, which I know we all know. He's one of those guys that just sort of helps in that situation. But I thought I would rather try to proactively fix my own problem and do it as minimally invasive as possible. And I tell you, I only really focused on that strength component that I just described for about 6 to 8 weeks. And then I think I built up the base to where I didn't have to continue doing all those specific exercises anymore. I think that's an example of how you could do it, right? I'm not saying everybody can do that, but I think that is one way you could possibly do it. Let's talk about case studies, because I think what would really be good, and if you're like me, I need to hear an example of all of these things in motion. So Heidi, why don't you pick a really good use case, and let's walk through that particular use case.
Okay. I might pick this use case just because it's like come up in our conversation. There's a client, I think it's okay to disclose this because they got a Rosie Award, so everybody knows who the client is. But Bryce Heiba started this plan, Lakeland Auto Mall, fully insured, converted it to self-insured, gave it to Liz and Taya, who then in Health Rosetta recently got this Rosie Award for it. But they're really implementing this nurse navigation DPC model. So it works out great because we're going to be meeting regularly with Nurse Nav and understanding the flow of claims that come in and working together to protect from the plan. They've got DPC that's on site in this case, and helping them understand what we do. We understand more about, like, are you a DPC who's like really lifestyle medicine? Can we refer cases where people are trying to lose weight to you, and really working collaboratively as a team together? So most of the cases at Lakeland Auto Mall we've seen direct. So they've come to us and we've treated them. And so far, within the first 3 months, about 14% of the population has used our services.
Okay.
So we aim for about 25%
I was gonna say,
engagement.
what's expected? So 25%, which is in line with the 27% and all that stuff that I just cited earlier. So about a quarter of the population should be engaging is what your target is, right?
Yeah.
Okay.
Yeah. And there's about 12 people so far that intended to have surgery who we're working with, and we think they do not need surgery.
All 12 of them?
Yeah, just within those 3 months.
Wow.
So that's just like an approximate idea of like what's possible. But then if you take that across a group, we have a 3,000 life group that we've seen, we're saving them, looking at like surgery intent to what we end up avoiding, the ROI is about 3x on them. So you can get a pretty good ROI where you're covering admin fees and then saving the plan a lot. So if MSK is like 20% and then you reduce that in half, that's like 10% less of overall healthcare spend on year one.
Yeah. Yeah, well, I believe it. Yeah, I was actually going to ask you that follow-up. Like, in your kind of broad thesis with Aware Health, what percentage of this MSK spend do you think is unnecessary? Is it about a third? Is it, more than that? Like, if we're looking at that $1 trillion, how much of it might be fraud, waste, abuse, unnecessary care, in your opinion?
If you exclude traumatic injuries, you fall, you break your hip, please do get surgery. If you exclude those, I honestly believe 95+% can be avoided.
Okay.
That's interesting because even if that number is off, even if it's half, there's a big opportunity. And I think why this is so important for employers to understand, especially self-funded employers, all the MSK, musculoskeletal stuff, almost all of that is paid dollar for dollar by employers because the vast majority of those claims fall underneath your specific deductible. So when I think about the difference between musculoskeletal costs for an employer versus a gene therapy, if I've got a $100,000 deductible and I have a $2 million gene therapy, I'm only on the hook for $100,000. The carrier's on the hook for everything else. But a $75,000 hip replacement or knee replacement or a $30,000 shoulder surgery.
Times 15 or
times
whatever.
15, 100% of that cost is mine as an employer. So if I can cut, even if the number's half, even if you're grossly overstating, which I don't think you are, but if you were, there's still a massive opportunity for employers to capture dollars back into their plan. And every dollar that's not spent is a dollar that's reserved to help pay future expenses. Maybe collect less in premium from the employees. It helps your budget as an employer. There's all these opportunities to create value for not only the employer, but the employees.
Yeah, go ahead, Mark. I know you.
No, and then, farther upstream for that employer too, like we work with manufacturing, and I was out at their production site. If you're on a line and someone's out of work for 6 weeks with a rotator cuff or 2 to 3 months with a lumbar spine fusion, that affects the whole the whole company, the whole production, the revenue, all of that. So you got the hard costs of you're shelling out for 15 joint replacements, and then you got all this downstream costs as well, that or lack of production and revenue. And this employer was like, we can't have our line disrupted so many times a year like this. When there's a 7,300 life group, 2 to 3% of those people, AAOS stats, American Academy of Orthopedic Surgeons, 3% of those people are getting surgery, and they're not there.
Okay.
So there's a big other upside of adding value, not value add, but adding value.
Absolutely. It's hard to estimate those effects, but I wholeheartedly agree that they're very important.
Yeah.
What I was going to say is it kind of that stop loss. I mean, I think through the lens of stop loss, like Chris was just describing, it's like, yes, we're not likely avoiding large specific claims, right? So if I'm a stop loss carrier, I'm not looking at MSK as a category that scares me necessarily in terms of what I would reimburse for specific claims. So those are your NICUs, those are your HAEs and your hemophilia, et cetera. But there is a potential to drive decrements to the attachment point, which is your overall that's your ag claims, that's your overall spend throughout the year. I could probably draw a connection between what you're doing and what you're doing, Mark, and I think you probably got data here, to say, hey, on average, if we are in place, we save 3% of plan spend, or maybe it's 10%, maybe it's 12%. And so then you continue that thought process, and now all of a sudden the attachment point's much lower. And now all of a sudden it's maybe more likely that a group goes from fully insured to self-funded, or stays self-funded, or does what Chris is saying is just save money overall. And so you have that coordination of incentives because the stop-loss carrier is now pricing appropriately on the ag for what you guys do. Have you seen this in your data, or do you have any proof of decrements or anything like that you could say?
I ask all the time.
Okay.
I have not seen it come across
stop-loss
yet.
carriers, let's look at Regenix data and look at the ag, okay?
Yeah, we've got plenty of data points on a lot of numbers, but it does make sense to me that that would be the case, and I haven't seen it actually happen yet.
I mean, it has to be feasible, right? I'm sure some of our partners are already looking at this and probably could tell me. But I'd love to know. And Chris, I know you're going to.
If they weren't looking at it before, it reminds me of the anxiety, depression leading into orthopedic. That is the light bulb moment for somebody to go back and look at that data and look at it at a different slice it differently.
Well, and you have experience with what we do at Pareto, right? And you sometimes might have a delta of 15 or 20% on your maximum exposure versus that fully insured option they have on the table right now. What if I could bring that down 8 or 10 or 12 points? Now, all of a sudden, that maximum exposure doesn't scare me as much because I trust the outcomes on the other side of being self-funded. And so we're not talking about a lot of change that could potentially move the needle pretty significantly for these employers. And so I'd love just maybe to see people start to dig into that and quantify what that savings. You'll have proof over time, right? You're 2 years into it, but you'll have proof over time what that number is. And I suspect it's probably pretty big.
Yeah. I came at all of this with we're avoiding X surgeries and we're saving this amount. We're also looking at previous claim spend before we participate and seeing if we can decrease it. And we just did a recent analysis where we separated users and non-users. And those that haven't used our platform, it's pretty cool. You can see their MSK spend stay steady. And then for those that have used our platform, it starts out almost as high as the other average. And then you can see the line just plummet over time.
Yeah.
So we're trying to understand how to look at the data across all of our customers in aggregate and start to see some patterns. But I think it's more sophisticated data analysts that would need to be able to do that.
Yeah,
so
absolutely.
it's really exciting.
But I think even this is relevant, Chris, because we heard this conversation at the True event, right? Talked about the fiduciary responsibility. Like if I'm an employer, do I have a fiduciary responsibility to start digging into this data, and am I overspending on MSK? It's possible. I'm more asking the question. I don't know the answer, but I'm starting to think down this path of, what did Hugh say? Fiduciary with a big F, right? Like it's here, it's now, everybody's talking about it. And this might also fit into that conversation.
Well, I think everyone's overpaying
Yeah.
because if you can avoid certain things, you're overpaying by doing those. I don't care if you got it bundled, if it's cheap, if it's direct contract. If you don't need it, that's overpaying.
Yeah.
And, it's not just my opinion. British Medical Journal, Journal of Orthopedic Physical Therapy, they've pointed out at least a dozen low-value surgeries that are no better than sham surgery or physical therapy use. So in the BMJ study, it was 250,000 patients that had adverse events just from those 9 surgeries. So not only are you overpaying, if we're ignoring this, we're putting people at risk unnecessarily.
Yeah.
So there's a lot going on here. And does that fall under a fiduciary?
Avoidance is 100% discount. Right.
Exactly. Immediate.
100% correct.
Right.
Yeah. But maybe why don't we real quick, just to make sure we don't say all surgery bad, right? Heidi, I know you'd be the first to say this as well, and Mark, I'm sure. Surgery is obviously, if my femur is sticking out of my leg, what are my options to get surgery, right? And so it's not the condemnation of the surgical procedure itself, it's the frequency and maybe necessity question that we're bringing to the fold, right?
Yeah, it's really the upfront skilled diagnosis and having a standardized approach that's important. So I've personally developed all of our back-end algorithms that triage when imaging's needed and when it's not, and when surgery is needed and when it's not. And then further diagnose once you can triage in those buckets. And so there's times that we refer directly to the ER for workup, or in the case of ruling out cancer for back pain, looking at labs and getting an MRI when it's indicated. So we're making sure that we reduce imaging and surgeries, but not missing the serious conditions. And so if there's even a 1% chance that you have a fracture, we're going to order imaging to make sure they don't have it. If there's a 0% chance of them having a fracture, why order the x-ray?
Did you say it only takes 5 questions for you to be able to, am I remembering correctly?
There are some clinical decision rules. They range from 3 to 12 questions, but if they pass all of them, there's a 0% chance. And some have 99% sensitivity, so it's maybe 1% chance, but very, very low. Where essentially, they don't need imaging.
Okay. What circumstances, Mark, where you go, Regenexx isn't going to help and surgery probably is your best bet?
So, we have a few things from our data. Male over 55 with severe hip osteoarthritis, not a good candidate for Regenexx.
Okay. You're not over 55, are you?
No.
Okay, good.
No, I almost take offense that he looked at me.
No, I didn't look at you for that reason. I know you're not. Multiple tears, ACL, MCL, medial collateral, medial meniscus, right?
So like combination of tears all at once.
Yes, same in the shoulder, combination of tears all at once. Those things need surgery to repair them.
We'll take them.
You take a look at them? Well, amazing.
We'll take
Okay.
So I talk to hundreds of advisors every year, and the same 10 that I've worked with over the years are the ones who move the needle and bring the solutions to employers. And my question is, why don't more advisors, they seem interested when we talk, it makes sense to them when they talk, but they do nothing after we talk. I get ghosted, or they don't do it, or they have a million reasons why they're not doing. I'm just curious why, when the answer is right here, and I'll just use Regenix, costs nothing to add to a plan, no PEPM. Why don't they implement these kinds of solutions?
Yeah, I think that's a really interesting question, and I can't speak for all advisors, but what I would say is there's probably a couple of different reasons. One is they're bombarded with information from all over the industry. There's musculoskeletal things, and there's diabetes programs and cancer programs, and just there's all sorts of things that are coming at them. I think part of it might be higher upstream management is, perhaps those are the folks that need to buy off on it, or they haven't approved it to be offered.
Yeah.
I would also think maybe there's some advisors that maybe just really don't grasp the concept. And then I think some advisors out there don't, I'm trying to think of the right word to describe this, but some advisors, I don't want to say, I'll say lead. You have to lead your clients. Clients don't have the level of expertise that somebody that's dedicated to the industry do. That's why they hire an advisor to get advice. And it's an advisor's job to lead the client. Sometimes you have to tell the client, this is what you should do, this is why, this is the result you're going to get. I do that with my clients. They need the advice. Some advisors don't do that.
I completely agree. And the one success I have with one advisor, he's added 43 employers. And I asked him, and he's senior to me even, I said, why are you so successful at this? He's like, what you just said, they hired me to be their advisor. And it's not necessarily a democracy when you work with me. That's why you hired me. Here's what we're going to do. We're going to monitor it. And if it doesn't work, we'll take it away. But you hired me to give you the best advice, and that's what I'm doing here. And I see him hitting it out of the park that way.
I think a lot of advisors, look, I've cut my niche in what I do by vetting things out and trying. I tinker. And sometimes I tell my clients, you're the first client that is implementing this program. But guess what? This is not one of those decisions that can't be unwound.
Right.
You have to be willing. I think a lot of advisors, and this goes for any profession, people don't want to be wrong. Mm-hmm. I've been wrong before. Mm-hmm. And you just go into it with this understanding that here's the benefit if it works. Here are the metrics that we're going to use to monitor it. And if it doesn't pan out, we can always unwind it. We can always do away with it. And that's how we have found the absolute best solutions that we work with, that we know what works, we know what doesn't. Because we've tried it, tested it, monitored it, used data. And that's, as long as you go into it with that sort of process,
right?
There's valuable opportunity out there.
And you're setting expectations appropriately. With your clients.
You have to.
Yeah.
You have to clearly define what does success look like and what does failure look like. Mm-hmm. And that way, if you start moving into that failure territory, you're able to advise the client that this isn't giving us the expected result. Therefore, is this the time to backtrack on it?
Right.
What types of things in the contract or the agreement would de-risk that for you? Is it 100% pricing at risk or money back guarantee? Is it no full ability to pull out whenever they want to along the way? Or I'm just curious.
Yeah, the ones that come to mind are going to be the ability to terminate. Mm-hmm. What do the conditions look like? Is it a 3-year deal? Is it a 1-year deal? Can they terminate any time with written notice, 30 days? Is a group willing to put some of their fees or compensation at risk if it doesn't perform? So usually we'll see ROI guarantees At least cover the cost that the employer's paying. I think those are kind of the two biggest ones. What sort of performance guarantee or early termination if it doesn't work?
We've toyed with the risk-free pricing, so like 100% money back guarantee, but there's still hesitation. So
I would tell you, just as a business owner and somebody that's also kind of involved in trying to, I won't say guarantee, but justify, the returns that we generate for clients. You don't want to do both. You don't want to give somebody an ROI guarantee and early termination. And I think because people sometimes don't understand what's involved, the time that it takes to generate an ROI, I think people are so quick to make a determination. Like, we've been doing it for 60 days. It's not working. Let's can it. It's no. It's you're going to have to give them one or the other. I don't think you can do both.
Okay.
I think we could get both. I mean, if we really believe in what we're doing and we think we can avoid surgeries, then the plan should have the control, or the consultant should have the control to be able to pull out whenever. Yeah. That's my personal feeling. But
I like that ability. I would take the ability to terminate more so than an ROI guarantee, because with an ROI guarantee, unless it's like very clearly defined how the ROI is going to be calculated, there can be disputes over did we meet the ROI or not. If the advisor and the employer determined you just haven't met the ROI, we're terminating, I'll take early termination with no penalty over an ROI guarantee.
How long do you give something to run before you pull the plug? A year?
Depends on what it is.
Yeah.
Depends on what it is. If let's just say we have a program like yours in place, and we look at the data, and we didn't have anybody that used the program, but we also didn't see very many musculoskeletal procedures through the plan, I think, okay, well, it just didn't happen this year.
Right.
I think it's just case by case, depending. You need to build, and no two cases are the same.
Right.
Yeah.
Yeah.
All right. Thank you.
That's really helpful. Yeah, I think one of the biggest things that I'm trying to do as a founder is to understand why people buy and don't buy. So it's very similar to the question you asked, Mark, but because we pitch the consultant pitches to the employer group. And then oftentimes, I get it, we're like one of many different topics in a customer meeting. But then we either get like a yes or a no. And so when we get a no, it's super helpful for us to know why. And we're not in the room, right? And so I think, like, when I asked the consultant what was the objection, they just said no and gave no reason. It's like, it's not very helpful. And so for me to understand that objection, if it's pricing, okay, let's do a 3-month trial where they're not going to get charged at all. If it's, I don't want to read through the contract or be held to a year commitment, we can put a clause in where, right away they can cancel at any time. So like understanding those objections helps us to meet the customer where they're at versus like presenting to the customer group, coming back with an answer, and then the conversation stops.
Yeah, I have a lot of thoughts on that.
I want to weigh in too, but you go first, man.
I have a lot of thoughts on that one. So if you are working with an advisor and they can't articulate why a client didn't want to pursue it, I would really question whether or not that's an advisor you should be talking to, because they either didn't present it or they didn't give it meaningful airtime to really investigate why the client didn't want it, especially if it's something that the advisor is recommending.
Yeah.
If I'm going to recommend something and a client is going to say, no, I don't want to do that, I'm going to dig a little deeper and understand, okay, well, why is that? What's your objection? You need to be able to uncover that, because that objection that the client is going to give you to that particular program is going to be insightful as an advisor. I need to know that as I'm digging and trying to build the rest of this plan.
I think that's a great angle to take. The advisor needs to know those reasons,
right? I think there's two things now. I'm going back kind of as a business owner's standpoint of what's the best way to approach the market. And the way you're doing it right now is through individual advisors. And I think that's a very valuable, because the advisors are the ones that have the trust. If they have the trust with the client, they should, to be able to make that recommendation. You need to find people that are passionate about what it is that you do and can clearly articulate it and the value to an employer. But I think the other way to approach the market, because that's kind of the bottom up approach, is the top down. Can you be bundled in as part of a bigger program? So whether that's with a captive supporting it and making it as part of the platform that they offer to all of their clients, that's probably the easier
question for you.
Question for you, which I wish I had the answer on that one.
But I also think not just the captive, but are there other programs out there that this could be bundled into? The risk you run there is that it becomes diluted because it's not focused on. It just becomes one of several things versus this is.
Well, I have two.
Go ahead.
I really want to weigh in here
Yeah,
because I've experienced this in my previous company, especially being in the early stages and helping them sell. Two things that I think we saw. One was we were so willing to do anything and everything for those clients that we would morph ourselves into whatever they wanted us to be because we were desperate for their validation. So that was an issue. The other thing is I think you could do is clearly define who your ideal customer is and build that to sell to them and be willing, if that person or that employer or that consultant is not an ideal partner, be willing to walk away because they don't fit that subset. Because once you start going down this path of, I'll change this contract here and I'll change this contract here, all of a sudden you're anything to anybody and you're not exactly what your original vision was. And so I would stick to your guns to a degree. Doesn't mean you're rigid, doesn't mean you don't pivot, but I would stick to your guns of what you envision and what you built. And if the person isn't interested at this time, it's not a no, but it might be a yes later on.
Sure.
You're just going to get down this path where all of a sudden you've lost your identity if you change too much.
Well, and I think two things on that. We could probably do this a lot of iterations,
Yeah.
but the first thing is the more customization you do, the harder it is to scale.
Yeah.
But the second thing is, to your point, is unbelievably spot on, is identifying your ideal customer. And I'm not saying the employer. I mean, I think if you said, could you do this for a fully insured group, or would you?
No.
Okay, perfect. So we've already
narrowed it down. Yeah,
That's
yeah.
guardrail one.
Yeah,
So I think
yeah.
about this like a stock screener. The more filters we put on this, the narrower the market gets. But the narrower you get, the more chance of success that you have every
Yeah.
time you approach it. So I think if you talk to an advisor and they said to you, all of my groups are fully insured, I don't really want to do fully or self-funded groups, would you continue to work with that advisor?
If they plan on writing self-insured groups, I'm staying in touch with them.
Okay, but
not
staying in
at that
touch, but
time.
not actively engaged.
Right.
Okay, right. So that's the second filter, right? So how do we build these filters to where you identify who is the ideal advisor? Maybe it's a firm and the advisor within the firm, but then also thinking about the end user of the product.
We know our ICP. How do I communicate it to somebody like you? Because most oftentimes what I see, even the really good health Rosetta advisors, who I feel like are great, they're like everybody just jumps to, well, those that have the highest orthopedic claims are going to be the ones that do manual labor work, like construction, but that's not true. Like sedentary workers, desk workers is
Yeah.
our profile.
Yeah.
That's ideal. And so that's 80% of the workforce. So I think what we find sometimes is consultants will use their own assumptions to pick groups, but then
Right.
it's hard for me to step back and be like, well, actually, these groups are the ones that could probably benefit most. So is that just like an open conversation?
Yeah,
or-
I think that's something. Well, I'll give you another tidbit on that, but I think it's important to be able to articulate that. Hey, you may have this perception this is the right group, but actually this is who we really would be able to assist.
Yeah.
But I think the bigger thing, since you mentioned a couple of groups of Health Rosetta and you mentioned a couple others, advisors that are trying to do the really creative work. I think one of the things you'll run into, and I'm a big analogy guy, is this cup of coffee. When I poured it, when I first took my sip of it, it like literally burned my mouth. I was like, oh gosh, like, I'm going to let that sit and cool off a little bit, and then I'm going to come back to see if it's hot. I think a lot of advisors, because there's so many things that are coming up, this has happened to me where I've started working with groups, and for one reason or another, it didn't work. They changed the product, the service didn't work, it didn't deliver the intended results, and therefore we discontinued. So I think there's a little bit of burnout of people saying, you know what, I like the idea, but I'm not ready to, I want to see how it plays out.
Yeah. There's a lot of that.
There's a lot of that. There's a lot of that. And I think it's really being able to articulate to the advisor, what's the value? And then if it doesn't work, here's how. That's why I'm always a big fan of being able to get out of it pretty quick.
Yeah.
I think Mark.
You mentioned bundles, and I've thought about this for a long time, because I'm coming at it from a whole different point of view, taking care of people, right? You handle how it gets paid. Here's how we can take care of people. What if there was a musculoskeletal bundle? What if you sold all of the two of us, right? And imaging, because you're going to need it.
Yeah.
Why don't you just
get a fresh pennies of MSK or something?
basically,
like that.
is that a doable thing? Like,
Yeah.
I mean, it's hard enough for me to sell me. I can't necessarily speak to but I know what we do is a false force multiplier. It's not 1 + 1. It's a big. Is that a doable thing, or does that just complicate everything?
No, I think it actually makes it simpler.
It seems
Look at what United Health has done. All the consolidation that they've done to whether it's owning the providers, the PBM, the data exchanges, like all of this has been aggregated and it creates a seamless experience. It's a bundle. That's all it is.
Yeah.
And what you're talking about is taking something that is highly fragmented and then consolidating it to make it a seamless
So we're
product.
rebundling, right? It's almost like a rebundle.
Well, that's really, as an advisor, that's what we're doing at the end of the day. We're saying, look, this bundle that's been created by United Health isn't the most efficient or the best cost way to do it. We're going to unbundle it, and then we're going to repackage up with best of breed of each of these categories that they fill. That's really what we're doing is we're saying, they do these 6 things for you. We're going to take it apart. We're going to put 6 new ones in that are independent, and it's going to create this new program with an ID card that's going to do all the things that this other did. But the
Yeah.
more consolidation you can put, because I think about consolidation, it can also be coordination.
Yeah.
Because if I work with you both independently, where's the connectivity? And so it's important to be able to build that bridge. And so we're
Absolutely.
doing it manually now.
Yeah.
But if there's a way, that's why I always go back to that nurse navigator. But if you really created it all as in one company and you said we're 2 clinicians that we work together, I can go down the hall or Teams or Zoom or whatever and make this work. I think that's a much more palatable, and I think that de-risks
Yeah,
the deal.
I
in
think
a way.
collaboration is so important.
Yeah.
And I think that unpackaging and repackaging is really good because those that partner with carriers are going to be like the big box players. They're not going to be handheld. They're like, we're early stage. We cannot fail with a customer. Like, I don't have the luxury of being like, well, it didn't work. We make sure we get engagement so that it does work. And so we're extremely motivated that way. Whereas like a big box player is going to be like, oh, 2% engagement, oh, whatever, you know?
One question I love to ask people, and this is probably a question you should ask advisors when you're vetting them out. I love this question because it tells you kind of the mindset of the person that you're talking to. Tell me something that you once believed that your mind has been changed on. And the reason I like that question, you reminded me of that question today, is when you asked me the question at the beginning of the podcast, I already had an answer in my head. And then when I heard you start talking, I thought, I haven't thought about that perspective before. Maybe I need to reevaluate my position on that. And so it's working with somebody that has an open mind that realizes what I've always thought to be true maybe isn't.
Yeah.
Are they dogmatic or are they open-minded?
Yeah.
And I think that question will lead into the type of person that you're talking to.
Yeah, that's a great question.
And I think because of my research and direct access, I'm like on my soapbox about that topic. And there is a way to bring DPC with the nurse navigation and all route patients together correctly. And I don't know exactly what that looks like right now. So I like you're challenging me on and like bringing your ideas to the table. It's good.
Yeah.
Well, and that's what
Your
we're
way.
talking about is like we build this continuum of care, right?
Yeah.
And Chris, like in your mind as you're hearing all this, right? I'm sure you're sort of tinkering in your head as you're reconstructing these things. So like, what are you thinking about in terms of like deployment or how this might stack on top of some of the other stuff that you're already doing?
I go back to how do we design this central point of contact that coordinates it.
Okay.
It's almost like a
really
care
is.
navigation,
Yeah.
care coordination, but it's got to be integrated.
Okay.
There's definitely value. I've personally used, what do we call this, regenerative medicine?
Yeah.
I've personally used regenerative medicine, and it has helped me. So I personally believe in it. I think it's a valuable step in the process. I think a lot of employers don't use it where they should. And I've personally used physical therapy that's helped me prevent having surgeries. So I think there's a tremendous value in it, especially in the landscape that we have today where everybody wants open and all you can eat buffet.
Right.
And send them to the sharks who are going to, and I say that kind of tongue in cheek, but surgeons make money doing surgery and that's their incentive.
Yeah.
And so we need to create some sort of options and process to get access.
So I have 2 points around that. I think advisors like you, and I don't know if you do, but they need clinicians involved in building these plans. They need a more thorough understanding about what's going on. Now, you don't have to go hire a clinician. You can bring solutions in that are led by clinicians, and now you've got a clinician on your team. And I was having lunch yesterday with someone, and they have nurses as their clinicians. And that's fine. But if they're not still seeing patients, if they never really did musculoskeletal medicine, if they're just looking at guidelines and studies, and they're making decisions on what you should build into a plan, that's not really a good use of a clinician in your plan. Now, so I have, I think more advisors need that because they're not making good, because you're not clinicians, right? I hear that all the time, where we don't understand clinical guidelines. We don't understand clinically where this fits in. Well, that's why you need a clinician on your team.
I think that's a great point because the advisors and the clinicians working together can develop the workflows. And nurses are used to following workflows. And so what is the workflow for this plan that will get to our same goal, which is decreasing cost and providing better quality care, right? So maybe as an advisor, working with clinicians to devise that workflow. And then there's even some new companies coming out, like Medify, for example, and using AI, they're pooling all the benefits information together and having one point of contact on their platform to then route to the right point solution. So there's a lot of innovation going on in this area. And I think it's super interesting because I do think it's the key to unlocking how we can collaborate and drive reduced costs together.
Yeah, I would say AI is obviously going to play a role in this if it's not already, right, of course. And then, so then it's hopefully it's being fed the right data and it's objective in its analyses. But I think if you can help with that diagnosis process. I've seen it with the thing Sniffle that I think I've mentioned before for primary care. I think it's going to just be a broad spectrum of this entire thing that we're talking about is we're going to have assistance with diagnosis and care coordination using AI. Why don't we do this, guys? Because we've talked about an hour, and I know we're probably going to do this one as a LinkedIn Live possibly, so we'll probably want to keep it around an hour. Why don't we kind of land the plane, right? I'm not going to ask you any specific question, but if you guys want to weigh in on a closing thought or leave the audience with something, what would that thing be? And I know I'm going to have to put somebody on the spot, and they're going to have to answer that. Mark, I feel like you might have one.
I'm going to say it a million times until I see it happening. We need advisors to work with us and to build these plans and stop analyzing and pontificating and talking about. Just do it. We're doing it. It's being done. Mm-hmm. It doesn't need to go get stress test anymore. It's being done. We can't do it without you. We need your help. We need to work together. You need clinicians on your team helping you build these things. Let's collaborate.
That's a good call to action. Heidi, Chris, who's next? Who wants to close it out?
Go around the table.
Yeah, we'll go. Yeah, Heidi.
Okay.
Yeah.
Being a clinician, I'll probably just put out a patient, tidbit here, but I think from a patient perspective, so often we're told to not do something that hurts, but the individual really likes doing that thing. Mm-hmm. And unfortunately, a lot of people stop doing the thing that they like, whether it's golf, whether it's running, whether it's pickleball.
Yep.
And the mission of Aware Health is to get people to do more than their baseline where they have pain doing something. So play golf better than before they even had pain. And really push the functional envelope because in the end, nobody dies from pain. Everybody is scared of pain. Mm-hmm. Nobody dies of pain.
That's fine.
We die of cardiovascular complications, respiratory complications. Yeah. And the worst thing we can do is be sedentary and rest and be cautious.
Well, that's such a downward spiral too when you stop.
Yeah.
Man. I like what you said there too, because I can think back to the playing days again. It's just I can draw a through line. It's like you always just wanted to try to get back to where you were before, and it felt like such a struggle. But you're even saying no. The goal is to get beyond maybe where you were in that baseline. And I felt like that's such a psychological hurdle to get back from. But it's true, right? Like, why can't you be better than you were before this injury if you're doing the right things to improve? Chris, why don't you close us out, man?
Yeah, I just have 3 words that have just kind of been running through my head this entire episode is awareness, friction, and simple. And what I mean by that is awareness is how do we create awareness for employees and employers that programs like this exist and how to use them. friction's usually kind of has a negative connotation, but friction's important. If you're walking and your shoe doesn't have friction, you're going to slip and fall. You need just the right amount of friction. And when I think of friction inside of a health plan, it's how do we make sure that we have the ability to get all the access to care that we need, but we have the appropriate friction to prevent unnecessary. And then simple is it needs to be easy for employees to use. And I think that goes back to that central hub, point of contact, somebody hand holding them. And I think a lot of times when advisors, this is the advice I would give to an advisor to kind of counter your point or to add to your point, there is a cost to add coordination. There's a cost to add solution providers. But if you do it in the right way and you bring this all together cohesively, it reduces the overall cost. So there's a way to do all of this in a meaningful way. We have to make it simple for the employee
100%
to access it.
And I think the only thing I would say to close out, and this is thanks again, Heidi, for coming down and on a second time. And this is a category that I've been exposed to now this year that I've started to realize how important it is as a category. But I would think broader than that is there's solutions out there that already fix most of the problems that consultants are seeing that employers are experiencing. And so it's being willing to find them, right? And I realize it's hard to parse which ones work and there's a lot of noise, but ultimately the solutions to the healthcare issues that we have today, they are out there and they exist. You just have to be willing to go find them. And then it becomes an element of trust, right? To ultimately find those strategic partners, put them in place and build that trust over time. And so my job is to continue to have these conversations and shine a light on these things. And hopefully the consultants and the employers that are listening will ultimately decide to reach out and pick it up. So thanks again, guys, for joining. Thank you so much for all your time and your expertise. This is always fun. And I'm sure we'll be doing this again sometime down the road. So thanks, guys.